Psychedelics to me like a very disruptive technology that is coming to psychiatry and maybe to all of medicine. And our field needs disruption, so I'm okay with that.
I'm Dr. Drew Ramsey. I'm your host, and we have a wonderful guest today, especially timely given all of the excitement and chatter about mental health and the psychedelic movement in particular. So today we have Dr. Julie Holland. She is a psychiatrist, an author, and a medical advisor to many organizations, including MAPS. She is a psychiatrist, psychopharmacologist, and then she's got a bunch of wonderful books. Most recently, Good Chemistry, The Science of Connection from Soul to Psychedelics. She has also written the book Ecstasy and the Pot Book, both complete guides, as well as Moody Bitches. And then what really got her onto the scene, Weekends at Bellevue. She's also a good friend and has been just a wonderful mentor and give me a lot of encouragement as in this stage of my career. So Julie, welcome. It's great to see you. Thanks so much for coming on the podcast.
My pleasure. Thanks for inviting me.
Julie, let's start a little bit. I went over your bio here, but I'd really like to start hearing in your kind of perspective, like where you are right now and kind of what you're up to make sure that everyone listening kind of beside your bio has a sense about you.
Where I'm at now, I'm like hunkered in a bunker right now with some torrential weather above me. But I was just joking with my husband that I saw an ad on the train for a retreat, and it looked like it was a picture of us. We were like stand up paddling on the lake across the street. So I live in a sort of retreat area, which I really appreciate, especially these days. But I'm living in the woods north of New York City. I'm a practicing psychiatrist. I have a pretty large private practice in psychopharmacology, so mostly prescribing antidepressants and ADD meds and things like that. I've been in the psychedelic community since the mid 80s, basically, since I feel like I became a member of the community when I became familiar with MDMA, and I took MDMA with Rick Doblin the last day that it was legal in June of 1985. I got very interested in MDMA because I was a pre-med, pretty sure I was going to become a psychiatrist, and I heard about a drug that was actually being used during therapy to make the therapy go deeper. So I got very interested in that.
How did you get interested, Julie, and not be scared? Medicine, and particularly medical students, and we're pretty nervous about the rules. We're pretty nervous about drugs. How is it you end up?
Not all
doing
of us,
MDMA
I guess,
with
is
Rick Doblin?
what I would say. Right. Well, I guess we could rewind a little bit. I mean, I grew up in the 70s in a big suburb of Boston. There were a lot of drugs around. I had older siblings. I was novelty seeking. Some people are risk averse and some people really like risk. They like adrenaline. It feels good to them. I'm one of those people. I like novelty. I like risk. I like, dancing on the edge of what's okay and pushing boundaries. That's where I'm comfortable. So I think it's important to know, where your comfort lies and what your default is. So, but when I was about 14, 15 years old, I was very interested in psychedelics, reading a lot about them, hearing a lot about them. It's like late 70s. And I was trying to find mescaline. I wanted to experience mescaline. And I inadvertently, in that quest, ended up experiencing PCP and had a pretty significant psychotic episode. I did not seek assistance and end up in a psych ward, luckily. I had some sense that this was from a drug, but I was definitely having psychotic symptoms. But it got me very interested in psychosis and schizophrenia. And then in the long run, I think it really got me interested in harm reduction and drug substitution and, our drug policy and why, if I was a 15-year-old person who was willing to take the risks of experiencing mescaline, why did I get PCP? That shouldn't happen. So I think those things, a lot of like that early experience was really traumatic for me, but it also informed, I think, my entire career. So I've started to think of it as sort of my origin story. It was a really scary night. But I don't think I have the same kind of fears as you do, let's say. I mean, everybody's sort of individual. But yes, doctors are conservative and risk averse in general. And I honestly think that the the lawyers in our country and our culture make the doctors more risk averse. We practice this sort of legal cover your ass medicine to some degree, and it can make us even more sort of fearful than we need to be. But when it comes to drugs, there's a lot of fear, there's a lot of projection. People are afraid of losing control, they're afraid of their shadow selves, as Carl Jung would say. And that sort of gets projected onto our drug policy. But our drug policy doesn't make a lot of sense from a medical point of view, from a science point of view. And so one of the things I do in my job is sort of fight and to reform the drug policy.
So many people listening have adolescents, and the idea of their how to help their adolescent maybe explore substances either safely or talk about it in a way that doesn't just, as you say, accentuate our fear. Um, and I'm wondering how you recommend, especially these days, parents go about that.
Yeah, well, I guess I should make clear I'm not recommending that any adolescents take really intensive uh, drug experiences on their own without being, properly guided and sort of observed. But it is true that adolescence is a risk-taking sort of bonanza for most people in their development. If you're ever going to be risky, it's going to be around adolescence, and there's all kinds of neurological reasons for this. Um, the most important thing with my own kids is that the lines of communication remain open, that they can always talk to me. They can always ask me something. I'm not going to be judgy. I'm not going to give them a hard time. I mean, with my kids, it was always like, call me, I'll pick you up. Ask me anything, I'll give you the answer. I'll tell you what I know. Let's just keep talking. Like, there's nothing off limits. So I think that's the first step. And I started that really early with the kids. I mean, they're like 8 years old, and I'm saying, like, no white powders, just getting those messages in really um, early and often. And it's okay if you sound like a broken record to your kids, because it does sink in, and some part of them will retain the stories that you tell them. But more than what you tell your kid, it's what you show your kid. And so I think it's really important to model healthy behavior and to model moderation whenever you can. For instance, I'm not much of a drinker. It's really easy for me to model with my kids that there's a glass of wine at dinner, and I very likely will not even finish that glass. And they see me sort of taking a sip and then saying, like, oh, my nose is getting numb, I better stop. But like, they see the behavior. I model the behavior, that I'm paying attention to how it's altering me and stopping when I've had enough. And just like around food, eat when you're hungry, stop when you're full, like very basic things. But you have to model that behavior if you want your kids to have that behavior. So it's all about harm reduction for me. It's all about accepting people are going to use drugs. Some people are going to use drugs, and uh, we the thing to do as a physician is to make sure those people are safe. Make sure your kids are safe. Safety first. There's a website for parents and teens about drug use. It's called safetyfirst.org, and it's a great name. It's what it should be. Primarily, I want you to be safe and have fun. And when the kids leave the house, have fun, be safe. Like, those are the two messages in whatever order. Go out there and enjoy yourself, but come back in one piece, mentally, not just physically.
Well, I mean, when you sort of talk about the fear, and I think the risk, I think that's one that we hear, is that people are going to lose control, and the second, as you just mentioned, that people aren't going to maybe come back mentally, or don't maybe know the tools for that. So you're mentioning in some ways a couple of I don't want to say rules, but I think no white powders. I think certainly my mom told me that one too, and I think that one has a new imperative. Right, in the past, that was about avoiding cocaine,
Right.
essentially,
And now it's
and
about
then
avoiding death. So the stakes are really high with kids.
yeah, you want to tell us a little bit about what's killing people with drugs in
Right.
America
So
today?
right now, our this the basically the drug supply on the street is completely compromised and poisoned by a glut of fentanyl. And so, first of all, some people have just started taking fentanyl because that's what's available, and it's much more potent than heroin or oxycodone or oxycontin. So it's just something to keep in mind, that for people who are choosing to use fentanyl, they have to be very careful. There's sort of a narrow therapeutic window before you get into overdose territory. But also, fentanyl is showing up in all these other drugs that aren't opiates because there's just a glut of fentanyl. So if you happen to, like, if you're somebody who wants to buy Xanax on the street, in the past, you could pretty much buy Xanax on the street. Now you may get Xanax or you may get fentanyl and you could die. So it's just the stakes are really high with unregulated drugs. And, one of the interesting things that's happening now in the psychedelic space is that everybody is hearing all these glowing reports about how, psilocybin mushrooms may be helpful for depression or MDMA may be helpful for PTSD. And it's true that our FDA may very well soon approve these medicines in the next couple of years, but people now want them now and they're not available. So they are seeking underground sources. We've got something going on in New York City right now where it's really easy to buy chocolate bars that have dried mushrooms in them, in these sort of bodegas that they're not selling them legally. They're not selling cannabis legally, but they're open for business and they're selling cannabis and they're selling mushrooms. So, we've got the situation now where there's a demand and people are going ahead and using these drugs, even though they haven't been FDA approved yet. And when they are FDA approved, there's going to be a lot of caveats. It's not just going to be go buy a chocolate bar at the bodega. It's, the idea was that the FDA approval is about using these medicines in the context of psychotherapy, that especially MDMA, that MDMA is packaged with psychotherapy. You don't just take the drug, that you talk and you work through your traumas. And there's always going to be recreational use and underground use, but the FDA approval is really based on a very particular way of doing things, where there's a lot of preparation, a lot of discussion beforehand about what your intention is going to be, what might you experience, and then afterward, the most important thing after the trip, I'm using air quotes here, is the integration, which is, what did you learn and what are you going to do about it? You just sort of had this altered state. You learned a bunch of things that seemed very important to you. Are you going to enact them? Where can you start sort of walking the talk of the trip? And that's the integration. And it's good that everyone, integration has sort of become a buzzword everyone's talking about. It's great that we're talking about integration. I mean, integer is about a whole number. It's about wholeness. I'm sure you've talked to your audience about this idea of health and wholeness really being one and the same, And so one of the things that gets integrated, I mean, integration is a word for all, when I was a kid in the 70s, we had integration. That meant that the Black kids from the city were bused into the suburbs, like there's that was called a forced integration. And, we could talk about that for an hour, but the idea is that you're sort of meshing things and you're making a whole. And the other important thing about integration is this issue of neuroplasticity, which is coming up a lot, which is that a lot of these drugs sort of help the brain to, in quotes, rewire itself, maybe make some changes in the circuitry. And you could think of it as sort of like a bush that needs pruning. And in the days after the trip, your brain is still in this plastic state. It's not just in this plastic state for 4 or 6 hours when the drug is active. There are days or even weeks, depending on what drug we're talking about, where, at least in laboratory animals, there is this extended period of neuroplasticity after these drugs. So it may be that it's not just what you do the day of the trip, but in the week after the trip, that really starts to set into the new sort of patterns that you're building.
There's a lot of excitement about all of this. And there's also a framing that like all neuroplasticity is good. And I've wondered what happens when people have a journey, and they leave and they have a horribly traumatic experience in the following 48 hours, or it's really they see things in their journey and it's really disturbing to them. I feel like somehow in the movement, neuroplasticity is always good in a way that's
Yeah.
kind of confused me a little bit.
Well, we know, I think you and I know it's not always good. I mean, the easiest example I can give of neuroplasticity that most people would say isn't good are the adaptations that happen in the brain when you're chronically using a drug, right? Like if you're using heroin every day, you need a little more, a little more, a little more. That's because of neuroplasticity. So, addiction is any kind of compulsive behavior or even tics, there's neuroplasticity involved. So it's true that it's not all good. It's not all for good. And, people can have really challenging experiences anytime they take a psychedelic, including cannabis. People can have very challenging experiences with a little too much cannabis. So, and if it's oral, it's going to last a long time. And challenging experiences, most people think, and I'm sure some people don't, but most people think that it's the sort of, good pain and good growth, and you have to go through it to process the trauma and figure out, you're going in circles, your life is a mess, you got to untangle things. It's going to be a little uncomfortable to untangle that stuff. And chances are there is some trauma that you have to process. I mean, there's big T trauma, there's little T trauma. There are people who have been, beaten and raped by family members and terrible things. But then there's all the little T trauma of benign neglect or, emotional abandonment or emotional neglect. We as parents know we're not always going to completely be there for our kids, validate them, mirror them. There are times that we're just, not available, not around. People are going to feel abandoned. That's little T trauma, but that all adds up. So even if you feel like you've never had any history of abuse, you may find that there's still some things you need to work through. It's almost like getting a massage where, like, you know, all your muscles could use a massage. There's like some kinks you need to work through, or some tightness, or things are kind of hooked up a little bit, and if you push on them they get loosened. And it's like that psychically. You've got, there's a certain amount of house cleaning that everybody's got to do, and some people have more to clean than others, and it often takes more than one trip to the dump to clean up a house. Sometimes you got to go back, you only got to one room, and there's a lot more to do. So some people need more sessions.
That's been one of the biggest lessons here is at Spruce Mental Health, as we've been integrating psychedelic medicine, is the clinical translation from research protocols, which by their very design are rather inflexible. If you have a bad first journey or a good first journey, how that then influences the next journey, the next integration, the dosing, the spacing, the content.
Yeah, it's great to not be doing research.
Yeah,
It's great that it's great that you can, it can be like a dance between clinician and client, and the dosing can change and the frequency can change, and you have a lot of options. And the most important thing, it's almost like if you're eating, you take a big bite of a sandwich, and then you sit back and you chew it and you swallow it and you have a little water, and you don't go right back in for, like, the people who have like bite, you're like, slow down, what are you doing, you're going to choke. It's really kind of like that, that you may not do it all at once, and you probably shouldn't do it all at once.
Yeah, I find that the integration piece for sure is the most challenging piece, how that is different than a regular psychotherapy session. And then I think the parts of integration that seem to be missing and that we're working really hard are the nonverbal integrations, the drawing, the art, the singing, the sound healing, the dancing and movement, that,
The
we're
body
not,
work.
yeah, we're
Yeah,
not
people
super
need
comfortable.
people need body work.
Tell me a little bit about that, Julie. What do
Well,
you?
I think, there, luckily, more and more people now are talking about somatic work and body work, and about books like, When the Body Says No, or The Body Keeps Score, or the polyvagal theory. More and more people are understanding. I talked about this a lot in Good Chemistry, the last book that I wrote. The basic idea with polyvagal theory, uh, there's sympathetic and there's parasympathetic, right? And everybody knows sympathetic is like fight or flight, and you need that for survival, except the truth is that you don't really need it for survival. You need it like 1 or 2% of your life to, like, run away from a bear or attack a wild boar. But, like, we, part of like America and the sort of pull yourself up from your bootstraps and Wild West and being a cowboy and independent is that we will say, like, fight or flight is what survival's all about. But the truth is, we are social primates. We have to be social in order to survive. Human species is categorized as obligatorily gregarious. We have to be social to survive. And so to be social, you can't be in fight or flight. Your social skills suck when you're in fight or flight. You have to be in parasympathetic, you know? And this idea of like the body keeps score is that when you are traumatized, you end up spending more time in fight or flight, and your body spends more time in fight or flight. And you can't, remember from medical school when they teach you about parasympathetic, that's rest, digest, repair, right? You can't sleep in fight or flight. You have to be in parasympathetic to sleep. That's rest. to really digest your food and make good use of your nutrients, you can't be in fight or flight. You have to be in parasympathetic, and that's digest. And then you've got repair. Wound healing only happens when you're in parasympathetic, right? If you're in fight or flight, your wounds don't heal, and you end up in this sort of your immune system is heavily modulated, let's say, in fight or flight. And where you really want your immune system to be is in parasympathetic, rest, digest, repair. So the repair part's really important because it's not just a bodily repair, it's social repair, right? We fuck up our relationships when we're in fight or flight. We fight, we run away. What you really need to do in a relationship is stay, not run away or fight. You need to stay and work it through. And you need to be in parasympathetic to really process and connect and be social. That's all about oxytocin, right? Parasympathetic is all about oxytocin. Fight or flight, sympathetic, is all about adrenaline and cortisol. Those things are fine short term, but long term, they're going to make you fat and edgy and miserable. And you get isolated when you're in fight or flight because you don't have good social skills. So all of this is to say that we store trauma in our bodies. If you see an animal like a goose or something and they get into a territory dispute, they do this huge thing with their wings where they shimmy their entire body. And you'll see it with dogs, you'll see it with horses, with deer. They shimmy, they shiver, they release energy from their body in this sort of shimmy. And we don't do that. We don't release our bodily energy, most of us. I mean, some people you're lucky to be like dancers or gymnasts, and they're constantly sort of moving, or maybe they go skiing quite a bit. But the average person is like sitting in the desk and sedentary, and the trauma just kind of gets stuck in the body. And so body work can be really important, and movement therapy and somatic therapy. And, one of the things that's happening now is this issue of touch and psychotherapy. And it's a very touchy area to
Yeah,
talk about
I want to hear
because
all about this because
there
I'm
are,
a traditionally
yeah,
trained psychotherapist. I've been doing this for
right.
20
We're not
years.
supposed to put hands on, right? I mean,
Yeah, so
at Bellevue, the funniest thing at Bellevue was that we had to medically clear our patients so they could go upstairs, but the psychiatrists wouldn't touch their patients. The ER docs came over to do the physicals. So it's just like there's such a traditional line where psychiatrists don't touch their patients, and therapists aren't supposed to touch their patients. And that's all well and good, but when you're in the midst of the throes of a psychedelic experience, you may want some grounding. You may want somebody to touch your hand or touch your shoulder or say I'm here. So you have to kind of set up the rules in advance of what touch is going to be okay and what touch isn't okay. And it's typically understood that chest to pelvis, you don't have to put your hands here. There's all kinds of other places to touch someone so that they don't feel like it's sexual and there's no question. So anyway, I think what we're going to end up seeing in time is that people will start to combine these somatic therapies, even massage, like deep muscle tissue work, perhaps with MDMA or with psilocybin might be helpful for some people. Some people really store trauma in their bodies, and some people only sort of get sick because they've been so traumatized and they can't communicate any other way. And sometimes illness ends up being a form of communication. So I think a person that's really good, Gabor Mate has got some great books. When the Body Says No, I think is a really great book that he's written about this. And sometimes, especially women, I think, we're pretty accommodating. Okay, honey, don't worry. I'll take care of it. That's fine. No problem. And it's all sure, sure, sure. And the body's like, And so, there'll be back issues or hip issues or, some sort of structural, I can't carry this weight anymore.
how do we weigh that in medicine, Julie, between the stories we hear so often, right? Of I've had this pain and the doctors never figured out, they never helped me with it. They sort of let me down. Medicine has let me down. And that kind of, in some ways, Hail Mary hope. It certainly happens. People store in their body and psychedelic medicine helps them. But sometimes it feels a little bit like we're kind of saving the psychedelic medicine with this notion that there's going to be this Hail Mary. You transcend the trauma, you do deep inner healing, you activate the inner healer, and it's all better. And I think what's really challenging right now is sometimes that's happening, and at the same time, sort of always thinking about physical pain syndromes as trauma. It's really hard to get that right.
Right. I mean, you can't, I think in psychiatry, we are taught that you first look for every possible medical explanation. And if you've really, turned over every stone and there's nothing there and there's no logical, medical, neurological explanation for what's going on, then you start to look for whether there is some symbolism in the symptom. I remember Rick Doblin talking to me about somebody he worked with once with I don't remember if it was, psilocybin or LSD, but they had a pretty strong psychedelic experience. And at one point in the experience, they couldn't move their hand. Their hand was kind of paralyzed. They got freaked out. They couldn't move their hand. But, instead of being like, okay, well, you're having some kind of tiny stroke from the psychedelic, it's making your hand not work. The person who was working with them was like, what does your hand mean to you? What has your hand done in the past? Can you think of why you would want it to be paralyzed? And it turns out actually there was a very good reason during the trip that there was significance. I'm not going to get into it, but the point is that what happened was that he had to be the one who turned off the machine of his father when they finally decided to, quote, unplug him. And, he had a lot of mixed feelings about the fact that he was the one to do it. His father brought him into the world. He's bringing him out. He used his hand. So, talks about it, moves his hand, fine, understand, So, there's always these amazing stories of people who get better from one trip or two trips, and they had this terrible thing and then it went away and it turns out it was all in my head. But there are also plenty of people who try to fix things with psychedelics and they don't necessarily get fixed. But maybe even if the thing doesn't get fixed, you may have a different relationship with the thing. Like maybe your chronic pain won't go away, but you will make space for living with chronic pain. So, there are crazy stories of healings and things, and there's always going to be that in medicine and psychiatry. Really rapid responses to treatment or interventions is not uncommon. And placebo response is a real thing. And you can see rapid responses to placebo. So we often have the potential to make huge changes in our perceptions, our experience, our bodies. And I think sometimes these psychedelics are really sort of giving us permission to unlock.
Julie, you're a psychopharmacologist. You prescribe medications for the majority of the patients that you work with. Sometimes it seems to me the psychedelic movement is very, very anti-psychiatry and very, very anti-psychiatric medication in a way that I would say kind of confuses me that psychedelics are a psychopharmacological intervention without the 5-HT2A receptor. A lot of this, we wouldn't be having this conversation. And at the same time, I see a kind of exaltation, right, of psychedelics, and at the same time, a loving of when there's controversies in the serotonin theory, or when there's a study that SSRIs, efficacy is being in question. I feel my feed on Instagram fills up with every kind of psychedelic influencer saying, "See, Prozac doesn't work," and it really bothers me because it feels the psychedelic movement has been pulled into something that its heart is profoundly stigmatizing. You don't actually get a menu of choices to treat your mental health that you get to choose because we have so much bias as a society about what you choose.
Yeah, I do. I keep saying it's a really great time to be a psychiatrist. It's a fascinating time to be a psychiatrist because our field is changing and psychedelics are changing, and psychedelics don't necessarily only belong in the field of psychiatry. First of all, I will say as a lefty libertarian harm reductionist, I really think that everybody should be able to experiment however they want, as long as they don't hurt anybody else and try to be safe themselves, and try not to cost the state too much money.
Is there an age where we start this? If I'm 16 and I want to do mescaline
how much
and PCP,
time do you have?
Well, I'm sort of curious
look,
when it's
so look, what I always told my kids is from what we understand, the brain isn't really fully done developing. It's not soup yet until maybe 23, 24, 25, depending on the person.
45 about daddy's almost, daddy just, as you can tell, he's almost there. He's a little slow.
He's almost there. But this, and it may be that there's a particularly vulnerable time in brain development. If you look at when people get their first psychotic episode, if they're bipolar, when people get their first psychotic episode, if they're schizophrenic, there's something about these late teens, early 20s that seems like a particularly vulnerable time in brain development. So it may be a really lousy time to take drugs, On the other hand, adolescence, with its risk taking and peer pressure, for a lot of people is the time to experiment. So, I mean, as much as, I'm telling the kids to wait, it gets harder and harder, especially, with like alcohol and cannabis, which are just, at every party or whatever. So, I mean, there's a few different issues here. So one is this idea that psychedelics don't only belong under the heading of medicine, that they can just also belong under the heading of recreation or personal experimentation or spiritual quests. I mean, there's all kinds of reasons why people want to take psychedelics. Some of my patients want to break their addiction to alcohol or other drugs. Some people have heard that it's good for quitting cigarettes. Some people have heard that it helps you taper off your antidepressants. I think all these things are probably true, and nothing is one size fits all in psychiatry. There are going to be lots of people who can avail themselves of MDMA and psychedelics for a lot of different reasons besides depression and PTSD. I think one of the interesting things now we're looking at, two interesting areas in psychedelics. One is that they have real immune modulating properties. You can consider them to be anti-inflammatory. And I think that there's going to be a lot of research around psychedelics and neuroinflammation, psychoneuroimmunology, just the whole endocrine inflammation connection with the brain. I mean, it's like you can call it psychoneuroimmunology, or
They're like Prozac.
There's a lot
They are
there.
a central anti-inflammatory.
There's that. And then there's also this issue of neuroplasticity, which makes them potentially very useful for brain injury, spinal cord trauma, head trauma, stroke. So all of that is being looked at. So it's really, in some ways, psychedelics are still in their infancy. And also this whole idea of finding non-psychoactive plasticogens is a terrible word. Neuroplastogens, this idea of psychoplastogens, all these words probably won't be adopted, but it's this idea that you can have the neuroplasticity without the trip if you tweak the molecule. We're going to see more and more of that. But I think there's place for everybody. Like there's space for people who just want to have personal explorations or small group explorations. There's space for people who need a therapist or a psychiatrist to work with them. There's a space for people who just had a stroke and don't want to trip. I think it doesn't have to be this either or thing. I definitely feel like psychedelics can be a very big tent. And, we just need all hands on deck. Like you need a lot of people to help with the therapy and to help with the integration. We need a lot more therapists. MAPS is training therapists, particularly we're looking for therapists of color. But MAPS is training therapists like as fast as they can to get ready for when MDMA is approved by FDA, because you're going to need to work with at least one and possibly two therapists.
Our entire team here, I think, is MAPS training now waiting, and the bottleneck seems to be getting the clinical experiential piece.
Right, exactly.
People are doing the training.
Sure. There's no bottleneck with the videos. There's bottleneck with face-to-face.
The bottleneck
they need a lot of people. Right. Because there's only so many trainers. I think that the longer the program goes on, the more there will be people who can train. But in the beginning, there's very few trainers and a lot of people who want to get trained. There's only one Michael and Annie Mithofer.
There's also, I think, the clinical integration piece. How does psychedelic medicine actually integrate into clinical practice? And so, as a psychiatrist, you appreciate it. The complexity of a history. And I think one of the frustrations I hear, and I certainly experience, is it feels like a lot of psychedelic clinicians get a pass. They don't have to take a very good history. They don't have to know patients very well. They can know them somewhat well, but a couple hours with a complex psychiatric patient. I just had probably one of the most complex people I've worked with. They saw a top psychedelic guide for 45 minutes, and now they're ready to journey. And I haven't spoken with them. There's not really a clear sense that they have taken a detailed psychiatric history or that they're really kind of trained or qualified to. I think my question is around, there's that part of medicine and psychiatry that gets a little protective. And there's a part of that I think is really stigmatizing, like patients need to be protected, they don't know. And there's a part of that I think is historical, that we've seen people over and over again mislead vulnerable populations with big claims and a lot of biased incentives. And I guess I'm wondering a little, like, who do you see getting this kind of right in terms of balancing great clinical care? Or maybe a better way to say it is, what's some of your advice for us?
Well, there's a bunch of layers, when when somebody comes in, I mean, one of the things somebody has to do is something like a medical clearance, which doesn't have to be, tell me about your trauma when you were 8 years old. It does have to be like, do you have a history of seizures? Do you have high blood pressure? Are you on any meds that are contraindicated? Like there's some sort of superficial medical clearance that needs to happen by somebody. And that could be a nurse practitioner or a PA or pharmacy tech or something. But there needs to be sort
Dr.
of.
Jeff, who's an ER doc, and we screen everyone medically.
So that's one layer, right? And then you have the sort of psychological screening, which is, would you benefit from this? What are the risks to you of this? Like, do you have trauma that needs to be processed? And the other thing that's really important is if a person is in an ongoing traumatic situation, you can work with them, but they're going right back out into that trauma. Things are not going to change very much. So there's this whole kind of like social, like if you had a social worker in your clinic, I think they should also be in charge of like the social integration, the community integration. If somebody has this intensive thing and then you just kind of send them back out where they're isolated or they're being abused, how much better are they going to get? So, there's a lot of work that has to do.
Clinical piece, Julie, that's so hard, right? Because, it's easy to say, and I think in a lot of the research trials or in a lot of the retreat model, you're away. In the clinical model, the husband you're having conflict with, that's the person who picks you up from the journey because that's the only person. And you go home and, the kids are upset. And as much as we try and create space and time and structure to,
right. I mean, that's why there is, I obviously not everybody can fly to Costa Rica for 2 weeks and stay somewhere. I mean, there's tons of retreats, there's like Cardea and Holos, and there's all these great places to go to. And it's great if you can go there because you don't go right back into your apartment. You stay there for 2 weeks and you work on everything, and then you fly home. But, most of us are not going to be able, be so lucky. I mean, that is a true luxury to be able to go away to a retreat. So it's true what you're saying. I was in Vermont at the Soul Equinox, conference a couple weeks ago, and Rosalind Watts from the UK was talking about this issue of people just kind of like going back into their miserable lives. And they've started a program. I think it's called ACER, ACER, and I think there's even training in this. But they're teaching clinics how to set up people with social integration afterwards. And part of it is doing good, finding something that you can do that is volunteering in some way, giving back, doing good. But then you kind of organize this whole community, everybody coming out of your ketamine clinic, for instance. They join this community of do-gooders. And if you're just new, you get a mentor who helps you figure out how do you want to do good, and here's what other people are doing. But then once you've been doing the program for a year, you become a mentor to new people coming in. So it's sustainable. And they create these sort of islands of connection with like 3 or 4 people who are really interested in dogs. So we volunteer at the shelter, this kind of thing. These people are interested in death and dying. We work at the hospice. And like they're all part of the group. They're all like the posts, they're part of your mental health center. And what's great is that you're giving to the community, you're volunteering where people need it. I mean, there's so many studies on volunteering putting you in parasympathetic, being anti-inflammatory, good for your body, good for your psyche, good for your soul. Dare I say the word soul and in public as a psychiatrist.
You wrote good.
I was just saying, as a psychiatrist,
soul to psychedelics. I mean, I think
I know, but it's like, but in psychiatry, we don't. Soul is for the priest. Psychiatrists don't. I mean, I talked about this in chemistry also. That like I had issues with the word soul being in the subtitle. It wasn't actually my idea, and I had to kind of go back into the book and add a little more soul and talk about it.
Well, I just think back on some of my clinical experiences with patients where, you see this bias we have against spirituality in medicine and how patients have been. I have a patient who's a devout Baptist and raised Baptist, loved to sing, and was just incredibly ashamed to tell me. And then when it came out, I was really like excited to hear about it and curious about their, just this whole big developmental piece about how their faith worked. And it instantly weaves into the treatment, right? If I know a therapist that as you go to bed at night, saying prayers to Jesus gives you an incredible feeling of release, I'm going to start asking about that. And I'm going to want you to use that tool. And so it is a way that the psychedelics I've found to be incredibly refreshing, I think, in my own practice, in the sense, and I think it's really challenging clinically from the clinician standpoint, of asking me to be more, asking me to resonate with patients on a level that I think all of us in therapy know is there. I sort of say, there's nothing new about the non-ordinary state for any of us in practice, because you spend all day in a non-ordinary state of consciousness. You're sitting with people hearing the most honest, most blunt, most primitively associative part that they can muster and saying, and you're receiving it and interacting with them in a way that's just, it's not ordinary, and it's wonderful. Anyone who's in clinical practice like you, and it's really it's like really being behind the scenes and hearing how humans are functioning. And so being asked to take it to the next level, right, to sit with people energetically, to sit with them spiritually and existentially, and also in the state of powerful medicines. I would say the part that I've found just as a clinician is really that transition to be able to do both, and opening up the space for something else that isn't as like concrete and definable, to be a part of my practice. The idea of taking someone to the journey room and saying, hey, we've set intentions, we've prepared, kind of like with an antidepressant, right? Realistically, here's likely what's going to happen, but we actually don't entirely know. And it's very, it just takes, I think, a lot of experience with these medicines for skilled clinicians to sit in that space responsibly, and one thing I've certainly enjoyed is all of the kind of activity, talk, and training about this, and the way that it really is kind of electrifying the mental health movement in a certain way.
That is what I wanted to talk about a little bit, is that, one of the things I think psychedelics are psychedelics are, to me, like a very disruptive technology that is coming to psychiatry and maybe to all of medicine. And our field needs disruption. So I'm okay with that. But it's going to, just like COVID really showed us huge cracks in the foundation of like the American medical system and how we deliver healthcare. Like COVID really showed us where we're not doing a good job. I think psychedelics are going to do that too. They're going to really shake up psychiatry, and it can't be business as usual where there are some doctors that see 6 patients an hour, right? This kind of work is not going to fit in with that model. Um, I see 2 patients. I see 2 patients an hour, and it wouldn't even fit in with that. We need new CPT codes. The idea that like the AMA and the APA has to develop new billing codes because nobody's ever like sat one-on-one with a patient for 6 hours, 8 hours. There's no billing code for that.
With multiple clinicians. I mean, it's interesting.
So
if you look at the listservs and psychedelic medicine, there's all this it's like panic, but like, hey, we're doing this work, we're learning about it, patients are getting benefit. How do we bill for it?
Right.
It's really,
it is, some of the metaphors I've heard are like, we're laying down tracks when the train's right behind us, or like I've heard like we're building the plane on the fly. I like that one. Building the plane on the fly. Like that is kind of what we're doing. We don't, we're making CPT codes, even though we've already been doing this work. We can't bill for it. We're trying to bill for it. Billing is a really boring, wonky piece of it. But like some people need to figure out this insurance part of it. If insurance doesn't reimburse clinicians for all this time, then it's not that we won't do it. It's just that there will be no equity. The people who have a ton of money will be doing it, and the people who have a ton of money, some of them have big T trauma, some of them have little T trauma, but the people who really need it with the big T trauma aren't going to be able to afford it. So this is an equity and a social issue, for the psychedelic movement, and there's a lot of talk, but there's not a lot of solution.
If you were going to ideally design our handling of that? We're in a small community. We're a fee-for-service clinic currently. I'm also very aware that we're in a growing Latino community here. We are on Shoshone land. There's a lot of intergenerational trauma here. I'm wondering, how do you recommend we approach equity?
Right. So the one thing is, if there is such a thing as a native person who is at all interested in the work you do, you hire them. If there are some people who are Spanish speaking and are interested in the work you do, you hire them so that there's representation in the clinic for the people that you are saying you want to come. So, I mean, that's what MAPS is trying to do too. It's like, if you want Black people, you need Black therapists. And I mean, that's just, it's like representation matters. So it matters in the clinic as well. So that is one thing. And the Rosalind Watts ACER model, it's not just good for the clinic, it's good for the community. The only issue that I'm a little worried about is this kind of HIPAA thing where you're not supposed to say who else is in your clinic. And here you have a whole program where you're hooking up clinic users. So they have to kind of opt in and opt out of confidentiality, right? You see, like, this is something they could do in the UK, but here we don't know. Can we do that? But I do like the idea that you're creating, it's almost like a 12-step program. Like, you're creating a community of peers, who can help. And it also lessens the burden. It lessens the burden of the clinic staff too. Like, the more you do things as a group, like, for instance, if you've got like 8 people you're planning on giving ketamine to next week, in a perfect world, you would have all 8 in a room with a couple of clinicians so you could prep them all at once. You don't have to prep each person individually. You can have 8 people in a room and say, like, hey, we're going to tell you, here's what we're going to do next week. This is what all of you are going to experience. And if you guys want to keep in touch afterwards, we think it'd be a great idea. But, like, again, I don't know what you can do around HIPAA with this. I think there's going to be more group prep, and maybe even group integration, and maybe even group sessions. In lots of indigenous communities, the sessions are group, right? The Native American peyote ceremony is a group. Ayahuasca ceremonies are group. Like, the old Kaikian Eleusinian mysteries were in a group. Like, there's tons and tons of history that these things were not done, I mean, even, in the old days, the shaman took the drug and everyone else sat around and just experienced what the shaman did. It didn't used to be that everybody in the group took the drug, just the medicine person did. But there is still that structure of the group.
I don't know if you find this when you guide. I don't take any substances while I'm guiding. And I find myself pulled into the psychedelic in a space that sometimes I've almost gotten like, it's just been very striking to get pulled into a dissociative mental state when you're with someone who's on a dissociative psychedelic medicine.
Right. Well, first of all, it shows that you are a good empathic clinician. That's what that shows me, is that you can really be there with your client when they're going through something to that degree. And it's a little woo-woo to talk about like auras, and like people's sort of psychic space. But I think in that situation where somebody's really expanded, it may be that they have like a bigger aura and it kind of envelops you a little bit. They're going through something intense.
I think a lot about like the energetics it gives. You sit with someone on your couch, like not, in a medicine session, and you feel so many different things. You get pulled into so many, we call it our countertransference, right? The feelings that get generated in a session. And I found those to be really, fascinating in the psychedelic space. And part of that, I just want to get back to this sort of tension you're talking about, which I think is really, which is around scalability. Right. And what's the difference between an individual medicine session, which for here, example, in our protocol, initially we like to give people the options to experience the medicine solo. But the group psychedelic assisted therapies are really fascinating. One around something that happens when you kind of squash the hierarchy, and a lot of the healing happens within the groups peer to peer. The other thing that's been fascinating to me, seeing some groups and witnessing being part of groups, is the way is a lot of folks in the movement talk about the medicine starts working before the medicine is given. That if you're there with an intention,
assembling as a group.
But it's sort of, you come to a group and we're going to share our trauma. That's one thing. We're going to come to our group and we're going to share something with the notion we're going to be journeying together later that day or tomorrow. Something happens to people, and I wonder. I get like tingles now talking about it, just because it hasn't happened in groups. It's really like,
yeah.
And again, the upside, it creates connection. Like, there's a couples therapist in LA, Tammy Johnson. I think I can close this Tammy. But Tammy and I were part of a training together I've spent a couple of days with her. I feel very psycho-spiritually connected to Tammy in a way that's a little hard to describe. Like as the clinic is forming and I may be having some challenging moments, there are folks like her who I've kind of met in the movement who that really like Harvey Schwartz, right, who just sort of stick with me. And I'm struck the little amount of time we spent together with the kind of way and impact that they have. And I was wondering
Yeah, I
what you
love
think
group
about those
work. I mean,
phenomena.
I think group work is going to end up being one of the answers to a lot of our questions in terms of how do we scale this, how do people pay for it, and how do we deal with this isolation disconnection problem we're all having. And the group therapy covers all of that. Like you can prep people together, you can run them together, you can integrate them together, and then they have friends. That's just like a win for everybody. So I imagine this is going to be happening more and more. I mean, the way the research was done with two clinicians and one client, it's not sustainable for private practice, and everybody
We've been
knows that.
trying,
So
Julie. We've been trying very hard. We've been using it. And I think especially when clinics are starting up and in this world, I think it's really actually important to realize the kind of initial phase, which our team is really I've been so appreciative to be here with Hannah Myers, a psychiatric nurse practitioner with lots of training from Polaris, and Jeff Greenbaum, who's the medical director of the ER, who has the certificate in psychedelic medicine and research from the California Center for Integrative Studies.
integrative
And so,
studies, yeah, great.
yeah, and so,
Yeah.
being able to be in a group and processing both the logistics of like, okay, how do you actually do this? And to experience things, and then work on improving them. I think that's it's a very exciting time. But starting with that, having a couple of clinicians, some of the challenges, like patients feel very watched sometimes, right? They want to just have a one-on-one interaction. I think that whole notion around safety and touch and boundaries, which is always of concern in
Yeah,
psychiatry
you
and
got
mental
to
health.
talk about some of this stuff ahead of time. On the other hand, it's really impossible to give an entire informed consent to somebody when you don't know exactly what they're consenting to. You don't know what they're going to go through. I mean, they can consent that we're going to give you this many milligrams, and you've said, touch me here, don't touch me there. But there's so much more that's going to go on that, they didn't. You can never be fully prepared or fully consented, I think, just because you don't know all the things that can happen. But it is important for there to be enough staff around, um, just for like peer supervision and peer support for the staff is important. It can be a lot to go through this with people. What's great
Yeah.
about ketamine, though, is people don't have to get off their meds to be on ketamine. And one of the things that's happening quite a bit now in the psychedelic space is that because of the drug interactions, like if you want to have an ayahuasca circle, you really have to get off a bunch of different psychiatric medicines. And if you want to experience MDMA, you can't be taking certain psychiatric medicines. And so there is a lot of deprescribing that's happening now, which could be good, but sometimes it's really destabilizing. Getting off psych meds is actually really hard, and you gotta, do it slowly and be supervised, blah, blah, blah. And so these people who are
And we're
like
not,
getting
and we
off
should
their
say,
meds
and we're
because
not
they
great
want to
at
have an
it. We're,
experience.
we're
No,
not
we're
great at
not
it in
great at it. This is
psychiatry.
another thing we're all just kind of learning, and there's a lot of talk about this like hyperbolic taper, that the closer you get to zero, the slower you go, which makes sense. And, some people need that, and some people just kind of want to rip the Band-Aid off. But the bottom line is that if you've gotten off meds in order to do a psychedelic therapy session, being off meds it can be a really vulnerable, destabilizing position for people who've been on meds for a long time. And then a psychedelic session can be pretty vulnerabilizing and destabilizing also. And so it can be like a pretty bad situation where, okay, so now you've had an intense session and you're off meds. Now what? Are you okay to stay off meds? Do you have to go back on meds? Like, it can be a pretty vulnerable time. And so there's a few sort of, uh, I don't know, like safety blind spots I think that people are having.
No,
I'm a
I
little,
totally
the
agree with this. That's that
interaction
part that
of,
gets
yeah,
protective, where I hear like, wait, what? You did what? You've stopped, you have a
right,
horrible, let's say,
right.
psychotic depression with lots of suicidal features, and you've stopped all of your meds. You're going to,
Because someone told you that microdosing would fix you or whatever. Yeah.
yeah. And I think it gets set up a little bit like the goal, which I can appreciate, is to not be on meds. The challenge then is if if you have a great session, good insights, and then symptoms come back, and medicines or something that's part of your journey and helpful to you, I see sometimes that's like either framed, as a failure or a failure of the psychedelic medicine. And I wonder if also it's important. We're talking about different populations in a certain way, or not different, but we're talking about there's a difference of you've not had psychiatric challenges. You're interested in deepening your spiritual growth. Maybe you've had a little bit of trouble with the trauma in the past, and you think psychedelic medicine could help you. It's a big difference between that and somebody who's had multiple hospitalizations and rehabs and multiple meds and 4 different providers and are really struggling in their mental health. And now they're in crisis because all their meds have been stopped. And also there's a pressuredness. If someone spent 2 months tapering off their meds and they present to us and they say, I'm really ready
Right,
to
and they want to
try
hurry up.
ketamine assisted therapy tomorrow,
So
we end up in a
what's
really
great
tough
about
spot.
ketamine, though, what I love about ketamine is you don't have to stop your meds, and more and more people are now saying that you may not have to stop your meds for mushrooms either, that it may just be ayahuasca and MDMA is really the issue. And you may just need to, more and more people are doing studies of SSRI plus mushroom to figure out whether you can still have the psilocybin experience without getting off the SSRIs, which is important work that really needs to be done.
Yeah, Tanmida Sethi in our group is a researcher on the psilocybin for healthcare provider burnout. So they're giving physicians psilocybin, I think just 1 dose, maybe 2 journeys, but I think just 1 journey. And she can't talk too much about the results, but I've
But
gotten
are
to
some
hear about
people
it.
on meds and some
They're
people
saying,
off
yeah, and the
meds, and
point is they're keeping people on meds. So it's been really funny in our group. We have Dr. Shauja, who's at NYU and was an author on the MDD psilocybin study where they took everyone off their meds. And then we have Tanmida Sethi, who's like, no, we keep people on our meds, and some people need a dose adjustment. And I think it speaks to where we are right now in terms of.
I am hearing, I mean, the current thinking, and I want more information on this, but the current thinking is that you may need to increase your psilocybin dose by 30 or 40% if you're on SSRIs. This whole issue of interactions between prescription psychiatric medicine and psychedelics, that thing deserves to be its own specialty. It's complicated. And I think people are really, these are some things that we figured out and some things we still don't know yet. It's just like we know you can pretty much take ketamine with anything. There's a few exceptions. And we know that that with ayahuasca, you pretty much can't take anything. And there's a few exceptions. And then there's all these things in between. And, understanding what the rules are and what's dangerous and what just may be ineffective. For instance, if you're on like a solid dose of an SSRI, most people won't feel MDMA. It's not that it's necessarily dangerous; it's just it won't work, right? So there's like what's dangerous, what's ineffective, and what combinations are perfectly fine. So the thing I love about ketamine is that you don't have to get off your meds. Also, it's legal. You don't have to play these games where you're afraid you're going to get somebody in trouble or they're going to get you in trouble because you're not following the law. And like those two things, okay with other meds and legal, and the thing I love about ketamine is it's doing so much bushwhacking. It is it's getting everybody used to the idea of a medication assisted psychotherapy. That's one thing. It's getting people used to the idea that an altered state can be beneficial. It's setting up the infrastructure for what I think may end up being a better treatments, or at least just more options, which is MDMA assisted therapy, psilocybin assisted therapy. So it's getting all that infrastructure in place. It's working through all these wrinkles and issues. What do we do with this, and how do we do that? So I'm really thrilled that ketamine clinics are popping up all over the place because they're going to turn into sort of mental health clinics where there's a lot of other options. And it would be great to include more somatic things. And I'd absolutely believe in like dance and stretching. And I talk to my patients about shimmying a lot. We talked about that earlier, about this kind of, letting
Shimmy the shake. I like the
physical
shaking
tension go
meditation.
through. And I talk to my patients about like, do the hokey pokey, like just like let some of your physical tension out. And one of the things that MDMA in particular is really good for enabling a really intense whole body shimmy. So that in and of itself is something you can do any day without the drugs.
I really appreciate the comments on ketamine. In part, I guess serves our bias that this is how we've been thinking about it here at Spruce Mental Health, which is we want to create amazing infrastructure for when psilocybin, MDMA, other psychedelics that are being studied are available, that we have a group of expertise, a group of experts who, both understand the pharmacology of it, but also the practical part, the guiding, the sending you home with a vomit bag and a special tea to help with nausea, the, making sure of following up in a specific way and having integration, because we really, know that matters. And then to have people have a variety, it is limiting now. It's a little strange as a clinician to see, we're trying to approximate the psychedelic studies. For example, alcohol use disorder is a huge problem here in Jackson, Wyoming. About half of the adults self-report. It's their typical ski town problem. You see a
Right.
study like this Johns Hopkins psilocybin alcohol use disorder study. It was just never, ever been anything ever like that in the treatment of alcohol use disorder, right? It's something like 80%, 85% reduction in drinking, and half of the people were fully sober. I mean, so obviously needs to be replicated, but the only thing we can do now and is approximate it with ketamine.
Well, there's actually a really rich history of using ketamine to treat alcoholism by this guy, Evgeny Krupitsky. And if you look at Evgeny's protocols for alcoholism and ketamine, he was having really amazing results. I remember like 20 years ago, this guy, Evgeny, was like trying to, tell us about ketamine alcohol, and it was just like, okay, whatever. But like he was onto something a long time before everybody else.
Well, and also that notion of, I think for a lot of these disorders, alcohol use disorder, PTSD, chronic resistant depression, the way you describe that kind of, being stuck in something and having often tried a lot of things and not getting out of it. There's something, Harvey Schwartz uses this phrase, a benign disruption, that we are going to shake things up a little bit, and it might be uncomfortable, but it's appropriate. Uh, I'm having a question about like sequencing, Julie. I've had this idea of wanting to empower patients to have options. For example, right now, psychedelic medicine fits into a protocol psychopharmacologically where you've suffered a lot. You've quote unquote failed at least probably 2 SSRIs and Wellbutrin, maybe an atypical antipsychotic. You've probably tried a number of different types of psychotherapy. And now that you have a real case of treatment-resistant depression, we're going to let you try psychedelic medicine. It's kind of how I often see it. And I wonder if we really need to reconceptualize that. I found myself telling patients
What
there
we
are a
start with
variety of things.
first.
Well, I don't know. I actually had this recently happen where a patient really was wanting symptomatic relief and kind of asked me, so why wouldn't I start with ketamine, see if that helps, because it sounds like it could work tomorrow, as opposed to trying an SSRI, which is going to take 6 weeks potentially. And I just wonder how you think about that,
Right.
and
Well,
both the
I think,
risks.
that's a great question. I think you say to your patient, like, that is a really great question. I don't know why we're not asking that question more often. I mean, it may be that down the line, we don't immediately start with an SSRI. It may be down the line that we start with MDMA therapy just to get the lay of the land and see where the kind of landmines are, and where the little pockets of trauma are that we get to go back and dig. And then maybe next time you have psilocybin to try to get to some of those pockets, or maybe you need another MDMA because you didn't quite even finish, surveying the landscape. But I mean, it could certainly be that eventually you go to a clinic and you avail yourself of a variety of things. And you may have some MDMA, you may have a couple weeks later, you may have a psilocybin session, a couple weeks later, you may have ketamine, you may join a dance group or a sound therapy bath, or.
What do you say to the critics who are like, whoa, whoa, whoa? The mental health clinic is going to be giving people like LSD and ketamine, and like this is just and mixing of it, right? I've been reading recently.
Yeah, I
that
mean, I'm not a big advocate of mixing, but there are plenty of underground therapists who really do mix, and they give more than one thing in one day. And then there are some retreats where you'll go for a week or two, and you'll be exposed to quite a few different treatments over that time. So, yeah, it's perfectly reasonable to be like, whoa, 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 what's going on? But eventually, I think that there will be sort of a mental health consumer who has some choices about how they want to treat themselves, and what their own sort of mental health regimen is going to be. What is going to make them sort of mentally fit. And everybody has got different requirements for mental health fitness, including dietary. And I know you love to talk about food, and we didn't talk about food very much. I mean,
Give
I
me a
think in
couple of
terms
your
of
thoughts.
psychiatry, well, I mean, my big, what I wrote about in Moody Bitches quite a bit, and then again a little bit in Good Chemistry, was this idea of inflammation really being at the root of a lot of our complaints. And so anything you can do to decrease inflammation is going to help you stay in parasympathetic, rest, digest, repair, be more social, and sort of, be more at ease. And so, an anti-inflammatory diet is better than a pro-inflammatory diet, and probiotics are better than antibiotics. It's like you want dirt. Yes, dirt. Yes, bacteria. Like fermented foods are great. I try to, drink kefir and kombucha and eat kimchi and yogurt, like you want pickled things. So like fermented things, anything bacteria laden, all probiotics, um, and anti-inflammatory food, on the other hand, I think that you can get into, there's something called orthorexia, where you're so worried about what you eat that it ends up being a diagnosis in and of itself.
Yeah, of course I'm
So,
feeling down. I didn't eat wild
you
salmon
know,
last night. This kind of
like,
overextension of the data.
dude, I had pasta carbonara last night, which I had been craving forever, and I finally let myself have it. And like my mouth was so happy to finally give myself something I wanted for so long. But like from here down, my body is miserable. It's just like, this is glue. This is gummy. This gums up the works. Why are you doing this? And like, I almost, was like joking, like, I wish our culture was more okay with like chewing and spitting out. Cause like, the whole mouthfeel, I was very happy, but I knew that my body wasn't going to be happy. So it is a matter of balancing, 80-20 or whatever. Like most of the time, try to do anti-inflammatory. Every once in a while, I have to sort of give into the cravings and at least understand where the cravings come from. Why is this food a comfort food? What about it comforts you? What were you do? What were you doing when you would eat this food? And like I have this thing around cereal, and I realized like whenever my parents went out, that's what I would eat. That's what was for dinner. They weren't around, I would eat cereal. And it became like this self-soothing mechanism. That I could take care of myself. If they're not home, I could always eat cereal. And so like for years, it was just like this weird thing around cereal. But I finally figured out like, foods have emotional meaning. Foods have symbolic meaning. And part of untangling how you eat is really spending a little time think, oh, you know what? My grandma made this for me. That's why I like to eat this. And so then at least you just be more conscious about it. Why am I craving grandma food? I'm lonely, you know? Is this sweet bread going to really make me feel like grandma, or should I go out and spend some time with an old person or make a new friend or just whatever, go for a walk? I mean, the point is that there's so much emotional eating that we're not in touch with. And, for years, it's just been about women. Emotional eating is women. But like, mothers feed their sons too. Emotional eating is sort of everybody's issue. It's just men can get away with it.
Well, when we think about the general stance of how men eat, I was really happy that there was a trial, the Amend trial, that came out last year, that looked at a nutritional psychiatry intervention in young depressed men. And first of all, 100% of the men who engaged in the trial had improved mood. 36% went to full remission of their depression. And when I talked to the researcher Jessica Bays about it, I said, like, how did you do it? And she said, well, one of the first things is the men just really felt seen. Like someone recognized that they were depressed and food was part of it and gave them tools. And then she noted, making suggestions that were concrete to them that aligned with some of their values, that they wanted to eat more protein. Well, it was great to educate them about beans and lentils. And we'll see. My hope is that we can begin to promote and share and create a clinical model where some of what I call like the new cutting edge parts of psychiatry coalesce and synergize. So the idea that, like, how do you incorporate the new nutritional psychiatry data and psychedelic medicine into a journey protocol, right? Because in general, when we're setting intentions, they're often around trauma, around depression. But what happens when you set intentions around self-nourishment or understanding the barriers to that, which are elusive to so many people? And what happens when the journey goals are around really bolstering mental fitness, or what oftentimes a lot of us take from journeys, right? A real sense of self. I remember I went to training really in a bad kind of a really bad identity neurotic spot a while ago. And I had this incredibly powerful experience, like a singular word, right? It just sort of said, like, you shouldn't be confused. You're a healer. That's what you do. And it was like, sort of obvious. I'm a doctor, right? That's what I spend my time doing. But there's something about the way that I received that message, that information, that one really demonstrated to me what some of the power of what happens in the psychedelic medicine space. That can be a little, sometimes hard to describe, right? Like,
Well, you're touching on a really important topic, which is meaning making. One of the things the psychedelics do is they infuse things with meaning. Everything becomes very meaningful and very important. But if every thought you have seems profound and meaningful, that could potentially be kind of dangerous, especially if other people are injecting thoughts into you or giving you ideas. So it is an important kind of weird caveat with psychedelics that everything seems so meaningful. This happens with ketamine. It happens with nitrous oxide. Even if I have laughing gas for a minute, I come back from that with thinking that I had this most profound, important insight. Like I've come back with like a jewel, and sometimes it just dissolves in your hand, and it wasn't a jewel, it was a blob of mucus. It's like it's run through my fingers.
And that's
it's
incredibly
gone,
disappointing, right? It's like, it reminds me of the college, it used to be college freshmen, not everyone, right? Where, they get super stoned and they write a bunch of stuff down. They have a big idea, and the next day we're like,
right. It's not what you thought, right?
Yeah.
Well, I mean, it's kind of like write drunk and edit sober. I mean, you're gonna have all kinds of ideas, but the vulnerability and the risk comes if you're in this state where you're kind of plastic and rewirable. I'm using air quotes again for those of you listening at home, and everything is super meaningful. If in the wrong hands, that could be a really dangerous place. Like you have to trust the people you're working with, and I mean, the example that always comes up, but it's actually a perfectly apt example, is that people who hung out with Charlie Manson took acid. Charlie wasn't with them. They went and did this crazy thing, and he wasn't even with them, but he had put the idea in their heads to do it. And, I think that the military was looking at psychedelics for I don't know what to call it. Mind manipulation, I guess, might be a way of thinking about it. So people are in a vulnerable, suggestible state, or with the case for 5-MeO DMT, they're not even really in their bodies, or ketamine too. They're sort of, they can't protect themselves. Physically sometimes, mentally other times. So they're really vulnerable. And so we just have to keep in mind that these are already vulnerable patients to start with sometimes, and then we're putting them into a super vulnerable position. And we really have to do due diligence and who's working with whom, how qualified are you? I mean, this is one of the great things about it being FDA approved and coming up from the underground, is that there's going to be a little bit more, hopefully, oversight on who's doing what. But there's always going to be an underground. I mean, it's, I don't, just like there's always going to be recreational use. There's always going to be things sort of off the grid that are happening underground with groups individually. It's not all going to be medically supervised. I mean, we have to prepare ourselves for more negative outcomes.
Well, I think there's that argument also in the movement that not all of it should be under the medical setting, and that kind of more libertarian. You sort of hear Rick say,
totally.
"Hey,
I totally agree. Like, you should be able to, grow your own pot and smoke it. You should be able to grow your own mushrooms and take them. I totally agree with that. But I think we have to accept that these are like power tools. They're like lasers. Like lasers can, fix a cornea, or they can burn down a house. Depends where you point them, how superficially, how deep, how long. Like, these are really powerful tools. And careful with that axe, Eugene. You're gonna need supervision. You need to read the manual and put on your safety goggles and all of this thing. And there, what is inevitable, I'm sure I'm not the first to say, but the more that people are using these, the more we're going to have some untoward consequences that we were not planning or hoping for. There's going to be abuse. We've already had like physical, sexual abuse in the research community, in the underground community. These things they happen in the retreat community. There anytime there's a power imbalance, there are going to be some people who abuse that. And so we have to talk about it. We have to admit that this is like a risk of therapy, that you are vulnerable and you are going to be manipulated mentally or physically or sexually or psychically or spiritually, that's got to be in the sort of consent form, like the global consent form that we're all like, yeah, psychedelics are so interesting and you're going to heal so much and learn so much. But there are absolutely going to be downsides and risks. And we just have to, talk about it, keep the lines of communication open, be willing to talk about it, and accept that some people have a higher tolerance for risk than others.
It feels like neutrality has gotten lost a little bit. That from a kind of classic, in some ways, psychodynamic model. Not that I need to be totally anonymous or that I'm not here. I think the relational model of psychoanalysis has really been very instructive in that two people are co-creating a dynamic. But it does feel with psychedelics, both because patients are in a vulnerable state. They've often had a lot of treatments that haven't helped them. There is a feeling in there, right, of activating the healer, of a lot of positive messaging. And I'm not saying that's wrong. I had that during Journeys, feels great in a certain way, but it does feel in the vein of what you're talking about, of a manipulation. And in a way that there's a kind of bias that we all have going in to Journeys, as much as we can couch it if we don't know what's going to happen, lean into things. And I guess I'm wondering about that in the sense of it's generally, I think, benign and well intentioned, but it doesn't feel like neutral to me.
Yeah, I agree. I think a lot of people in this space aren't neutral. There's a lot of excitement. There are a few people who are, really trying to just remind everybody to be cautious and that there are a lot of landmines. There's a few people who are doing that, but most of the people are like full steam ahead. This is great. So there
Yeah, I
absolutely
feel
should
like
be more neutrality.
contrarian, and I don't want to
There aren't
anymore.
that many. Well, I mean, we need contrarians. You need people who are going to challenge what's going on every step of the way, and we also need like supervision. Like we really need a governing body. I can't believe me when I'm saying this. Like we need someone in
I
charge,
know.
but you do need, like a board. Like there are, people are forming. There's like I'm going to get these names wrong, but there's like, Psychiatric Practitioners of America, or there's like APPA or APMA, there's like psychedelic medicine practitioners. There is a board being formed, but it's really early days of like, okay, who will be board certified in this specialty? Like this is a whole new specialty in medicine, and there's no board certification process right now, and there's no one to answer to about how you're behaving right now. So we need that kind of supervision. We need those governing boards. I cannot believe I'm calling for this, but I am.
Julie, you've been really generous with your time. I was hoping you might share a little bit about two things, both related to mental fitness. One is what you do. You've mentioned a lot of things: living in the woods, being outside. You have a
What
really
I
creative
do, yeah.
life. Yeah, you have a wonderful partnership. I've gotten to, and so I'd like to hear a little bit about what you do for your mental fitness regimen, is question one. And question two, mental fitness revolution is this idea that there can be revolutions for us in our mental health. And I wonder if that's happened
Yeah.
to you ever.
Well, I mean, I don't know what to say about revolution. I mean, I think it's, there were a number of steps along the way where I had little revolutions. One was I read a bunch of books by this woman, Janine Roth, who really taught me about emotional eating and, respecting like what my body is actually craving and things like that. A lot of work around eating and craving and urges that I thought was incredibly helpful. So that was in med school, and that was a big turning point for me. Also in med school, I had this one residency. I had like a rotation for 6 weeks where I was in the middle of nowhere in Pennsylvania, and I taught myself to run. I was a third year medical student when I finally started jogging. That was a revelation for me. It was huge for me to start to feel what that felt like to go jogging and biking. So I was not that physically, I don't know. I was just kind of like a blob, I think, all through undergrad. And I mean, I was fronting a band. I was singing in a band, right? So I was how I looked was important to me, but I don't think I was very healthy about how I went about trying to have a look in the '80s. So I mean, I see pictures of myself from college now, and I'm just like remembering how unhealthy I was and the way that I was going about trying to sculpt the 80s body that you're supposed to have. Anyway, what I do now, I mean, Moody Bitches really got me to appreciate anti-inflammatory diet more, and supplements. So like, I absolutely take vitamin D when it's not summer. I take probiotics. I really love CBD, and I take CBD every day and sometimes twice a day. I take
People
these
have a lot
capsules
of
from.
questions about that. Just is there a way, if people are interested in that they should?
There's a company called Bluebird Botanicals. I have no vested interest in them at all, but I think that they make really good CBD products. There's a lot of CBD out there. It's hard to know what's what. Bluebird Botanicals makes something called like complete capsules. It has CBDA in it, which is like even more potent than CBD. So I personally like it. I'm a middle-aged woman. I've got aches and pains. CBD really helps me with like my arthritis pain, but there's a supplement called Boswellia that I've discovered that is really good for stiffness, for my patients with arthritis that have stiffness. You get up in the morning, it hurts to walk. You get out of a car, you're all stiff. This Boswellia, I don't have any stiffness anymore, and I love it. So now I take D, Boswellia, CBD, probiotics. Those are sort of my regular supplements. Anti-inflammatory diet when I can. I try to avoid talk about avoiding white powders. I definitely try to minimize flour and sugar. Yeah, emotional eating is a real thing. If you can check in with yourself about how you're feeling and what's going on with you before you start eating that thing, like that can be really helpful. Just being in parasympathetic before I eat is important.
Yeah, I guess I was also just wondering more
Besides food.
besides
Supplements.
food, just in terms
Yes,
of,
other things.
as
So
a
here
person.
are all the other anti-inflammatory things I do. I go out. I'm trying to be in nature, because being in nature puts you in parasympathetic. I really like water. We live near a lake, so I go, swimming or stand up paddling on the lake. And in the winter, we go cross country skiing or ice skating on the lake. And so I am outside in nature on a regular basis. I try to do my cardio outside when I can, so that I'm checking off a few boxes. If I do cardio outside, I'm exercising, I'm in nature, and I'm getting sun and air, and all those things are important. I have a lot of friends. I cultivate social things. I'm a musician. I get together with my friends and play music. I play music with my husband, with my kids. Being married is very stressful. I find it really stressful to have like a committed relationship where you're really trying to grow all the time. Like growth is kind of painful, and a lot of conflict. The saying is like conflict is growth trying to happen. A lot of the fights and stuff, it's really about one of you needs to grow up a little bit. And so I'm just thinking more about when we have these clashes, because they're inevitable. There's so many people think that if you're in a relationship, you're supposed to be happy all the time. And it's like, if you're with somebody year after year after year, you're gonna have huge dust ups and blow ups and fights and really intense conflicts that need to be worked through, and not sort of run away from. So that's another time when you really want to be in parasympathetic with your partner, so that you can kind of mirror and validate them and not just get reactive. And so that's a big part of mental fitness and mental health, is knowing that there's going to be conflict in your long-term relationships, and not expecting them to be perfect. And just you're constantly, I think of it as like you're always untangling knots, you're always trying to keep things more open. And I don't know what the other metaphor is besides untangling, like massage, where you're trying to work through like the knots in the muscles. Sometimes it hurts. Like a really good massage feels terrible, but afterwards you're like, oh, I can move my shoulder again. Like
I think
you have to kind of go in there.
there's a pain and release, and at times, and a lot of
There's
times,
good pain and there's bad pain, but like growing hurts and conflict hurts, and not all conflict is abuse. And sometimes conflict is really just growth trying to happen, and you gotta work through your shit. So you work through your stuff on your own, you work through with your partner, with your kids. I mean, everything is kind of an opportunity for you to be better and more integrated and more whole. Integrity is an important part of integration, right? And integrity comes from authenticity, which comes from interoception, which means you have to actually know how you feel to be authentic and have integrity, And I don't know about you guys, but I think women get a lot of messages growing up that we push down how we're feeling, that you ignore your hunger, you repress your sexual desire because it's not good to be hungry or horny. And so you separate off these parts of yourself, and it may not be until you're 50 something that you can finally sort of get in touch with your body and what it actually wants, what you're really hungry for, what kind of sex you want, or, so there's this whole idea of like authenticity, or, in good chemistry, I think I call it emotional integrity. Acting in concert with your own integrity. That's one of the keys to, I think, to mental health and fitness.
Interoception is
Just
such a
knowing
great
what you
word.
want.
Yeah, knowing
Yeah.
and being able to describe that idea we have in psychotherapy that are putting this like complex mishmash of stuff into a set of words, so we can have some sense of understanding, mastery, communication about it. I really love throughout this episode, Julie, the way that you're talking about parasympathetic, because we do think about it as like rest, digest. But there's something about the way you're
Repair.
applying that to our psychology and our emotions, right? It's about not just digesting food. You've got to be in parasympathetic to digest emotional stuff well. And then the other
Exactly.
part is how you're talking about
Yeah.
repair and connection, which I'd never thought about parasympathetic as the nervous system modality of connection. Right, that you have to be in that state. If I'm fighting you or running from you, I have
Right.
no
We're not
connection to
connected.
you in a dynamic, meaningful, evolution, growing way. That those all those qualities we hope for in good relationships. And I think it's such a wonderful way for us to think about some of this, and in some ways think about what the psychedelic movement is asking of us, right? Which doesn't always feel parasympathetic, right? There is a lot of excitement and fight or flight kind of feeling sometimes, and to really have us settle down from all the hyperbole, and to think about this as a very disruptive time, and to be maybe quite respectful of these compounds and their power. As you said, these are laser beams. It can be destructive or it can heal your vision.
Yeah, and some of these compounds have an ancestral lineage that is really worth looking at and digging up, and some of them don't. And that's okay. I mean, MDMA has no ancestral lineage.
I love
Um,
how people always try to
and
find that.
so
Like,
we
no,
kind of
no,
have to
it's
make
in that
our
one
own.
plant. And I found that also with the ketamine. It was we have a really wonderful
Ketamine
spiritual
just has no
director here.
ancestral lineage, obviously.
Yeah,
Right.
and Amy is a very just wonderful presence here in our clinic, very experienced guide, and we were having a conversation about a patient's experience who've been very dark and very gray, and she said, we probably shouldn't overinterpret this. There's a very common experience with a lower dose ketamine that just it isn't really dosed in a way, and so the person is going to have a darker, grayer,
I
less kind of
agree.
experience. And let's not make it like, oh, of course, your life's so gray, it has all this meaning. And I think that's one of
Right.
the one of again is I appreciate you extolling some of the virtues of ketamine. I think one of the ones I've noticed is just how pharmacological it is. It's on and it's
Yeah,
off.
that yeah, there really is a threshold dose. I mean, I remember when I first learned about ketamine, and traditionally, and no ancestral lineage, but traditionally it was 150 milligrams IM. That was the psychedelic dose, a shot of 150. And what people would say is if you gave 70 or 60 or 70, people were in this horrible area where it was like they couldn't blast off. They were stuck with all the energy of the
Mhm.
rocket
Yeah,
without
they
the
kind of
rocket
describe being
blasting
in a
off.
little bit of a loop.
Yeah. So, the dose makes the poison, they say. Some people say, some of the time.
Yeah, I was just going to say, you've been really generous with your time. I want to thank everyone for listening and thinking about a revolution in your mental fitness. And I hope you hear a lot of optimism and excitement from one of the premier experts in the field. Julie has been thinking about psychedelic medicines for her entire career. Please check out her books, particularly Good Chemistry, the most recent one. Uh, Dr. Holland, where can everyone find more information about you and your books? And we'll put these in the show notes as well, everybody.
Well, everything is on my website, drholland.com, or naturalmood.com, weekends at bellevue.com, moodybitches.com. It all goes to the same wonderful place.
Well, I just want to thank you for being a friend, first of all, and thank you for being a
My pleasure.
psychiatrist who I just
Also my
appreciate
pleasure.
your strengths. You've just stood up for a lot of things that psychiatry generally has demonized. and you've done it with real grace, and you've done it in a way that really I always feel like heard and connected. And I feel that you celebrate the parts of us that are contrarian, and the parts of us that are exploratory, and the parts of us want to be free, and as you've even heard, and the parts of us that maybe need a little board regulation. And I just really appreciate that
It's
about you
all
and how
one
you keep us all
integer.
talking.
Yeah, my pleasure. And you. Thank you for the work you're doing and keeping us all talking and listening.
Well, everybody, it's been another great episode. Please share this with your friends, especially anybody who is thinking about psychedelic medicine. I think it's rare to get somebody with this depth of expertise, both clinically, psychopharmacologically, but also as a person in development, and as a parent and a wife, and someone who really can appreciate the real world value and challenges of these medicines. I look forward to seeing everybody on a future episode. Please share these with anybody who needs this info. Dr. Julie Holland, I can't wait to have you here in this clinic someday doing some fun stuff.
I'll have to get back out there.
Going cross-country skiing together like we did a couple years ago. It was actually one of the very first things that happened after we moved to Wyoming is somehow Julie and I connected, and then suddenly Julie was in my house presenting to the Teton Youth and Family Services, which is like the largest group of clinicians, and talking about psychedelic medicine. And I was thinking, this is an interesting introduction I'm having here. It's
you got to be careful when you mention, I'm living in Jackson now, you should come out and visit. I was like, you're going to be sorry you just said that. Be careful what you throw around. It was a great trip. Really great trip.
I think experiences like that make me less careful with what I throw around, Julie. Having you come here was inspiring. Kind of every step of the way. When I would feel worried, challenged, freaked out, I kind of hear a soothing comment from you, something a little funny and quippy, and like, what are you so worried about, Ramsey? And so you have this very fun, almost older sister feel in my life that I appreciate it, and I hope to impress you and make you proud of what we're doing here.
Well,
and I can't wait to
you
share
already
more
have
as we get better. So thank you so much.
Yeah, it'd be fun to come back out sometime. Great. You too. Everybody, enjoy.